I've really enjoyed the relationships that I've made in the College of Medicine, but also outside, including with the Pepper Center. So um, moving right along, I have no relevant disclosures, only to say I am a Pepper Center scholar from 2024 to 2026. It's really been a joy being able to do work alongside the Pepper Center, and the mentorship being provided to me is really very special, and I'm grateful for the folks at the University of Florida Pepper Center for that. Today, we're going to talk about the description of cardiovascular metrics and traditional clinical endpoints, for example, MACE, that are used in cardiovascular research. We're going to specifically talk about limitations of these measures, compare traditional clinical endpoints and outcomes to patient-centered and patient-reported outcomes, and then review examples of patient-centered outcomes currently used in cardiovascular research, including some of the work that we're doing here. So what are clinical metrics? Clinical metrics can be summarized by how hospitals or individual physicians are measured. There has to be a way to measure. If you don't measure, you can't improve quality. Clinical metrics are often objective and clean. They're usually clinician-measured endpoints relying on standardized assessments. These are all the ways that we keep metrics clean. The timing is almost always short term, so either in hospital or immediately post-discharge, 3 months, 6 months, et cetera. And then oftentimes hospital reimbursement is linked to achievement of certain clinical metrics. And in the same vein, penalties are linked. So hospitals have a lot of investment in trying to ensure that our clinical metrics are met. What are some examples? So the National Cardiovascular Data Registry, or NCDR, gives physicians who do primary coronary intervention or stenting procedures for heart arteries very, very carefully crafted clinical metrics. So we have a database called the CathPCI Registry. It enrolls every single, if you're a participating hospital, which most are, especially most academic centers, every single patient who has a stenting procedure in your hospital has to be reviewed in the CathPCI registry. And we actually have an entire department that uploads the data to this registry. Some examples of clinical metrics are PCI in-hospital mortality. This is obviously separated by all patients, and then, of course, patients who have urgent or emergent indications. Bleeding post-PCI, acute kidney injury from the contrast, post-PCI, new need for dialysis, 30-day readmissions, and then, of course, the usual death, emergency surgery, stroke, need for repeat revascularizations. These are some examples of the metrics that are currently compiled for a very, very common procedure that takes place in hospitals throughout the country. Similarly, all of us have heard what the American Heart Association get with the guidelines for heart failure. This is how hospitals that take care of patients with heart failure are measured. So are patients discharged on a beta blocker? Are they discharged on a medicine called an ARNI, an angiotensin receptor inhibitor? Do you do some assessment of their left ventricular ejection fraction when they're admitted to the hospital? Do you get that surface echocardiogram? Do you have a post-hospital follow-up for heart failure patients? And so on and so forth. So it's very important that hospitals are in tune and have the appropriate processes set up to meet these metrics, because again, hospital reimbursement and penalties are linked to these clinical metrics. Clinical metrics are very similar to traditional clinical outcomes, what we call hard outcomes. As opposed to how hospitals or physicians are measured, traditional clinical outcomes are how trials are conducted. These also tend to be objective and clean. They're also usually clinician-measured endpoints. They rely on standardized assessments. But the timing can vary depending on the study question protocol. And in fact, a lot of our hard outcomes are post-operative in-hospital outcomes, but they can go for as much as 5 to 10 years, depending on the protocol of the trial in question. Some examples of frequently measured hard outcomes are death, myocardial infarction, stroke, and bleed, for example. This is an example of the Society of Thoracic Surgery American College of Cardiology registry for all patients who have transcatheter aortic valve replacement, or TAVR, which is a minimally invasive aortic valve replacement in the entire country. Every single person who has a TAVR in this country, their details are uploaded to this online form, and all of this data is gathered, used for publication, and most importantly, used for quality improvement as well as policy. These are some examples of data that is gathered. There's some very serious complications like annular rupture, aortic dissection, which is usually intra-procedure. There's some post-op complications like bleeding at the access site, any need for cardiac surgery, and then some seemingly unrelated complications like the development of COVID-19, the need for stenting procedures postoperatively, the development of stroke. So all of these, as you can see, are hard outcomes. They're mostly binary. Did the patient have a stroke or did the patient not have a stroke? Easy to measure, objective, clinician derived. And so these are examples of hard outcomes. So how does this compare to surrogate clinical outcomes or soft outcomes? So soft outcomes are how trials are conducted when event rates are low. So for example, if you're studying a condition where the risk of death is actually not very high, for example, in PCI stenting procedures for stable ischemic heart disease, oftentimes it's really hard to have death as your outcome because death is not common. And so you would have to run that trial for 40 years to see if there's a difference between your control and your treatment arms. So oftentimes we use soft outcomes or soft surrogate outcomes for trials when the event rates are low. These are easy to measure, standardized, quantifiable. They're frequently based on imaging because that allows for some objectivity in something that is inherently less objective. They're associated with hard outcomes often, but usually tangentially. So I'll give you an example, but they're not clearly associated with hard outcomes. Some examples are the RV, or right ventricular to left ventricular ratio, for pulmonary embolism trials, improvement in left ventricular ejection fraction for revascularization trials or device trials, and change in LDL levels for prevention trials. This is an example of the STS TAVR registry again, and I'll just bring your attention to the bottom of the screen where we are collecting a lot of data on post-operative echocardiogram assessments for these patients. So what is the change in ejection fraction? What is the change in aortic valve gradients, areas? Is there a development of a secondary valvular pathology? So these are all examples of soft outcomes that is important to know is objective, but is not necessarily the most important, if you will. Another example is a very, very large trial called the Seattle 2 trial, which is studying whether or not invasive treatment of pulmonary embolus improves outcomes. So obviously, all of us would like to see a trial where we show improvement in mortality after pulmonary embolus therapy, but that trial would be very expensive. It would have to run for many years, and specifically in patients who don't have massive pulmonary embolism, the event rate is relatively small. And what this trial showed was that there was a statistically significant improvement in this RV to LV ratio by using the treatment arm, which was a very specific kind of technical procedure, compared to standard of care, which is usually systemic blood thinners. And so, when they reported the outcomes of this trial and at one of our national meetings, everyone was very happy because there was a statistically significant difference in this ratio. And this ratio does matter because we know that if in patients who have a pulmonary embolus, if they have persistent right ventricular dysfunction at hospital discharge, their likelihood of having a PE-related mortality at 3 years out is higher than folks without persistent right ventricular dysfunction. So it's important, but it is a surrogate marker, right? This trial didn't actually show that patients did better. It showed that their ratio was better. And this is important because as a practicing physician, if you tell a patient, congratulations, your RV to LV ratio has improved tremendously, I'm not sure a patient really understands what this means, how to interpret it, whether or not they should participate in the treatment arm or, follow the recommendations that you may be recommending. So it's very difficult to take surrogate endpoints and have high quality shared decision-making conversations with our patients because they're surrogate, they're technical, and it may not be interpreted in the way that we need it to be interpreted. So what's the most common example of a traditional clinical outcome or a hard outcome? MACE, major adverse cardiovascular events. This is the most frequently used composite endpoint in cardiovascular trials. It's composite because it includes multiple different endpoints. It includes, most traditionally, cardiovascular death or non-fatal stroke or non-fatal MI. Now, one of the very unfortunate parts of MACE is that it can also include other things, or it may not include what was specified there. It could also include cardiovascular events in general, heart failure admissions, ischemic cardiovascular events, if you're being more specific. So there's not a standardized definition of MACE, although the one that is written here is the most common. What are the benefits of MACE? Well, it is very easy to measure. Death is the best endpoint because it can be captured even outside your institution using things like the Social Security Death Index. So when a patient dies, chances are you can know for sure whether he or she is dead. Non-fatal MI or stroke is easy to adjudicate compared to other endpoints. And so even if it doesn't necessarily occur in your institution, using lab data, imaging data, you can usually adjudicate it fine. The reason to use a composite endpoint is that it increases your statistical power. So if you do have a disease where the event rate of death is lower, then adding other events like non-fatal MI, non-fatal stroke will improve your ability to notice a difference between two arms, a treatment and a control. And I in no way want to imply that these outcomes do not matter. They absolutely matter, right? Most patients want to live longer. They want to be free from MI or stroke. And they matter not only to patients, to physicians, but they especially matter to healthcare delivery institutions for whom quality improvement and quality reporting is critical. But there are limitations of MACE that we should be aware of. The outcomes, importantly, may be of unequal importance. So MI, death, and stroke are different from the patient perspective. They're actually different from the physician perspective as well. And by making them equal, it actually obscures the trade-offs between one versus another. There's also a major time to first event bias. So once you achieve one of those composite endpoints, MI, stroke, or death, you have achieved your endpoint. And so what happens subsequently kind of matters less, especially if your first event is MI and stroke and by definition, non-fatal. There's also heterogeneity and moving goalposts like we spoke about. There's inconsistent MACE definitions across trials, and this complicates comparative analysis studies. And then there's limited resonance with shared decision-making and value-based care. So the most important subgroups where function and quality of life matter the most: older adults, patients who are frail, patients who have cognitive impairment. This is where these three outcomes may be of less importance. Perhaps they value quality of life type outcomes more. So there are major limitations. This is a schematic just kind of helping you understand that. So let's say, for example, we have 3 patients, 2 men and a woman enrolled in a cardiovascular trial. All 3 of these patients were randomized to treatment. And so they underwent, for example, let's say surgery, major surgery. The first patient dies quickly. So he has the surgery in the hospital, he dies, and he achieves his event, okay, in red there. The second patient, our woman, she has the surgery, the treatment arm. She has postoperative complications like pneumonia. She has blood loss, anemia, has not achieved the endpoint of MACE. Then she gets discharged. She just doesn't do well. She gets discharged to a skilled nursing home. She was admitted from home, so this is a big difference, where she needs help with her activity of daily living. She finally is discharged from that nursing home, but she's wheelchair dependent, major functional limitations there. And then within 6 months to a year, she gets readmitted. As you can see, she has not achieved the primary endpoint at all. She doesn't have a non-fatal MI, non-fatal stroke, and she has not died. But you can imagine this woman has had a tremendous decrease in her quality of life, her functional status, perhaps her mood. We have no sense of what's going on with her, despite not, quote, not achieving the primary endpoint. We have our third patient here who has the treatment arm. He's left in a non-ambulatory or minimally ambulatory status from his surgery. He then gets readmitted, has a stroke, is left bedbound, and eventually dies. He achieves his endpoint during his stroke admission, but it really doesn't do him justice because he's left completely dependent in his activities of daily living, and eventually he dies, which most of us will argue is a, quote, worse endpoint, although for this patient, perhaps the most quality of life limiting endpoint was actually his stroke. So you can imagine our trials don't do a good job telling patient A from patient B from patient C. Also, what MACE doesn't capture is all the other things. So on the left upper screen there, do patients return to work? On the right side of the screen there, are they able to have meaningful relationships with their family? Do they get to spend time with their family outside of their interventions? And then what is their mood? We have no ability to capture this with our traditional clinical endpoints. So really, we're at a point of a paradigm shift in outcomes research. And this is a quote from Dr. Mario Godino, who's a thoracic surgeon, who was quoted when discussing the limitations of MACE. We have been designing clinical trials for trialists, not for patients. And that's what I hope that we can speak of for the rest of the day today. And why does this matter? Because cardiology is shifting from event counting to life impact. So of course it's important that patients live longer with the therapies that we do, that they have less MI and stroke. But really, we need to focus also on what impacts their quality of life. And this is even more true as our population ages. Patients themselves often prioritize relief of symptoms, improvement or at least maintenance of function, their emotions, their independence, and their, quote, time at home, the time that they spent at their home with their loved ones and not in a hospital setting or an outpatient care setting. The composite of hard outcomes, like I showed you with that graphic, fail to capture treatment burden and recovery trajectory. A person who's in and out of the hospital has a much different time than someone who is discharged and is thriving. And then more importantly, regulators like the FDA are increasingly recognizing the patient voice and are really calling for patients to be involved in the clinical research that we're doing. An ideal clinical endpoint, therefore, would include all of these things: easy to capture, objective, easy to understand, accurate, valid, clinically relevant, and I would add personally meaningful to the patients that we're taking care of. So the rest of the time will be spent making the case for patient-centered outcomes. So these are outcomes that reflect what matters most to patients as measured by clinicians. This can only be known when we ask patients what matters to them. They're measured by combination of clinical data, administrative data, and the patient caregiver experience. Examples include independence in daily activities, functional status, return to work, this concept of days alive and out of the hospital, and home time or time at home ratio, and we'll go through all of these. So how are patient-centered outcomes different from patient-reported outcomes? Well, they're similar but different. They are direct reports from patients about their symptoms and their functional status. They are not left for clinician interpretation. They're directly from the patient. They can be survey-based, and they often are, but they're often standard and validated as well. So that's useful for clinical trials. Some very famous examples are the Kansas City Cardiomyopathy Questionnaire, or KCCQ, and the Seattle Angina Questionnaire for trials of revascularization. Of course, some of the limitations are listed here. They're subject to missing data. They can be onerous sometimes. Some of these questionnaires can be, 30, 40 questions, and they require literacy and cognition to be able to fill them out. And that may be a problem for some of our populations. So really, we have to figure out a way to meld patient-centered outcomes, patient-reported outcomes, and traditional clinical outcomes into what we all believe are meaningful outcomes for our patients. This is a study I'm working on through Johnson & Johnson, an investigator-initiated grant I received. And through this study, I interview patients who have very complex coronary artery disease or blockages, and see what their experience is and what they're looking for in terms of revascularization strategies. So a question I ask is, what is the patient experience when deciding between open heart surgery and stents for complex coronary disease? And I just wanted you to, if this works, I wanted you to get a sense and sort of listen to what we're dealing with here. I'm going to play it.
Okay, so I just want to confirm again that you agree to be recorded.
Excuse me.
Absolutely.
Sir. Turn to for,
I believe that.
all right. So think back to the first time you heard that you may need a procedure, okay, for your heart artery blockage. Where did you turn to for information?
Well, I was here. My son is a nurse. I consulted with him. My family, after I finally made the decision to have the stents versus the surgery, and I'm 80 years old, okay, or almost 81. And I don't want to live, my mother lived to 99 and a half. I'm not interested in setting a record. So I talked to them. I talked to the doctors and the nurses here. I decided to go with the stents because, first of all, I'm a chicken when it comes to pain. And I think having your sternum cut open and then plated and wired back together would be painful over a longer period of time than having the stents put in. I live alone. I will return to that life. I don't want to have my family, and they're all here in Gainesville, have to take care of me. And I think with the surgery, I might live longer, but they would be on the hook for that. And I took care of my mother and my father. Mother the longest, 15 years. And that's wearing. And I don't mean any disrespect for mom, but it's just wearing. And I don't want to do that to my children. Although one of them refuted that yesterday and said that he's more than happy to take care of me. But anyway, I think when both sets of doctors talked to me, and they were very open about everything, and that I appreciate that. The honesty helps. It was much easier for me to make a decision with the good information that they gave me, and with my situation as it is, and my health the way it's been up until this occurred. It just was much easier to make the decision to go with the stent.
So I hope that, it's such a meaningful conversation I had with this patient, and he said it better than I could have ever said it. It's only when we speak to these patients do we understand what their goals are, how they find meaning, and how we should design our trials to find meaning for our patients as well.
Oh.
All right, so what are some examples of patient-centered outcomes? So there's functional and participation outcomes. 6-minute walk test, easy to measure. Your New York Heart Association class, which tells you their degree of heart failure. It's useful, but it's really very clinician assessed and subjective. It's best to pair this with other patient-reported outcomes. Your ability to return to work activities, caregiver burden, and then goal attainment scaling for individual priorities. This is an example of some of our work where we took 34 patients and their caregivers, and we tested for caregiver stress and burden prior to minimally invasive aortic valve replacement, and after 3 months after and 6 months after minimally invasive aortic valve replacement. And what we found, and we were very happy to find this because this was our hypothesis, was that caregiver burden was improved immediately after valve replacement. And this improvement was sustained 6 months out. So they had a relatively high degree of caregiver burden beforehand, which was improved and sustained. And that's so meaningful because when you are counseling families and their loved ones about undergoing this procedure, you can say, oh, by the way, as a caregiver, you may also have benefits of this procedure as well. There's also time-based outcomes that patients understand, days alive and out of the hospital, right? So it's not just okay being alive. You also want to be out of the hospital. You don't want to be, living in the hospital for months. Your time at home ratio, the amount of time you spend at home versus in a medical setting, this includes the hospital, nursing homes, rehabilitation placements, all of the above. Your discharge destination. Do people who come from home go home, or are they more likely to be admitted to a nursing home, skilled nursing facility? And then, of course, a quality adjusted days at home and out of the hospital, which incorporate some of these quality assessments as well, is even stronger. This is some of our work in patients who have advanced leg artery disease, how they fare when they undergo transcatheter aortic valve replacement. And what we found is of course, we measured traditional outcomes and they do worse. But importantly, patients who have advanced peripheral arterial disease who undergo minimally invasive valve replacement are less likely to be discharged home and are more likely to have any major complications, postoperative complications. This is important. I think this is meaningful when you're discussing this with patients who have 2 life-limiting conditions. What's their likelihood of having a post-op complication, and where are they likely to go when they're discharged from the hospital? This is an example of a study of days at home and out of the hospital comparing surgical aortic valve and minimally invasive aortic valve replacement. And what they found was if you have minimally invasive aortic valve replacement, you're likely to spend 27 more days at home compared to folks who undergo surgical aortic valve replacement. This is important because for certain patients, they have the choice. There's no clear right answer. And so they have the choice of undergoing one versus the other. And these are the kind of conversations that may help them decide one versus the other based on their own goals and priorities. There's also this idea of hierarchical composite in patient-centered outcomes. So this is called win ratios. These attempt to prioritize the components of sometimes hard outcomes by patient importance. And of course, you have to talk to the patients. You have to do some qualitative methodology first to decide what is the hierarchy of importance. And then you use pairwise comparisons to avoid time to first event analyses and pitfalls. Okay, and I'm going to give you a good example here. So this is an example of a win ratio hierarchy, and it's just using hypothetical ABCD outcomes. And after qualitative analysis with patients, caregivers, and physicians, care providers, we've decided that outcome A is of the highest priority, B second, C third, and so on. Okay. Then if you have a patient this is a trial, you have a treatment arm and a control arm. Neither of the patients in terms of outcome A experience that outcome, it's a tie. Outcome B, it's a tie. In outcome C, one of the control patients experienced the outcome, so the win of C goes to the treatment arm. And outcome D, it's the opposite. One of the treatment arms experienced the outcome, so the win goes to the control arm. So officially there's 2 ties and a win each, but the overall win in this particular of patients goes to the the treatment arm because outcome C was deemed a higher priority than outcome D. Okay, this is a clinical example of that. Okay, so in this specific hierarchy, it was decided that death was the most important, stroke second, heart failure hospitalization third, and then quality of life improvement fourth. And so in a similar scenario, the 2 patients were tied in the first 2 outcomes of death and stroke. In outcome C, or hospitalization, the treatment patient had 2 hospitalizations and the control patient had 1. And so the control won. And in the quality of life improvement, the treatment patient had a good quality of life improvement, but the control did not. So the treatment won. Okay, so this is an example of how we can prioritize the actual outcomes. This is a clinical trial example of this. So most recently, there's been a lot of interest in the treatment of the tricuspid valve, and specifically in patients who are not good surgical candidates. So this was a randomized controlled trial. And their primary outcome was actually a win ratio of the 3 components listed here. Least, quote, important Kansas City quality of life change, second most important, heart failure hospitalizations, and third most important, death or the need for tricuspid valve surgery. And this was actually taken from qualitative conversations with physicians in this space as well as with patients. And what they found that as compared to standard of care, which is medical therapy for tricuspid valve disease, patients who underwent surgical treatment, minimally invasive surgical treatment, had total overall higher wins, so a win ratio of 1.84, which favors the treatment, and also wins in every single category. So in the Kansas City questionnaire change, a much more significant number of wins, 18,000 versus 5,000. In heart failure hospitalizations, 6 versus 5. And in the need for tricuspid valve surgery or death, 7,200 versus 6,900. So really the most gain was in the quality of life improvement, but the overall win ratio favored treatment. And so really like an interesting patient-centered way to combine hard outcomes and patient-reported outcomes. So this is really nice because instead of saying to a patient as a physician, congratulations, your right ventricle to left ventricle ratio is improved, you can say something truly meaningful. You can say, compared to a patient who is treated with medications, if you undergo this procedure, our trial shows that you are less likely to die or need open heart surgery, less likely to be admitted to the hospital for heart failure, more likely to feel better in terms of your functional status if you undergo this surgery. And a patient can take what he or she needs from that. Perhaps they're most interested in their functional status, then they can take that. And if they're less interested, they can consider what the other outcomes mean to them. So again, much more meaningful in terms of the conversations we have with our patients. I would argue that patient-centered outcomes are even more important in vulnerable populations, like those who are aging, and specifically the area of my interest is folks with Alzheimer's disease and related dementia. And this is because ADRD is always a life-limiting condition. All of those patients who are diagnosed with dementia or related disease are going to have an early death, and that's because dementia itself is a life-limiting condition. So oftentimes you're studying 2 life-limiting conditions, aortic valve disease and ADRD. How can we possibly understand the interaction? How can we possibly understand what patient goals are if we don't focus on patient-centered and patient-reported outcomes? And what if our traditional idea that mortality is important is actually not the main motivator for our patients? Like that conversation we heard earlier, he was not interested in living forever. He wasn't interested in, quote, breaking any records. He wanted to feel better, maintain his independence, and not be a burden for his family members. This is some of our work we've done in this space. This is looking at patients with ADRD in terms of a claims-based diagnosis and looking at their outcomes after minimally invasive mitral valve repair. And we found that the likelihood of discharge to a nursing facility and the likelihood of the development of delirium is much, much higher in folks with dementia who undergo this procedure compared to folks without dementia. That's important because if the patient sitting in front of you and their caregiver is asking, how will my loved one fare with this procedure, understanding that they were not enrolled in the trials, right? Because we do not enroll patients with dementia in most of our trials. You should be able to give them good information about how the specific population will do in terms of the outcomes that matter to them. This is some unpublished work looking at the association of dementia with patient-centered outcomes following an area of my specialization, which is complex and high-risk coronary artery stenting, So folks who have complex heart artery blockages who are not candidates for traditional open heart surgery because of their age, because of the presence of conditions like dementia. How do they do after stenting of all this disease? And what we found is they actually do similarly when it comes to heart outcomes. They actually do there's a non-significant difference in inpatient death. So they don't have major complications that increase their risk of inpatient death after the procedure. But they're much, much more likely to be discharged to a higher level of care, much less likely to be discharged home, and have a lower overall home time ratio. And this is very meaningful when counseling patients. This is the adjusted analysis of that. As you can see, your likelihood of being discharged to a higher level of care if you have dementia undergoing stenting for high-risk coronary disease is 1.8, almost 2 times. Your likelihood of being discharged home is almost half. And, clearly patients with dementia are less likely to survive than patients without dementia. We know that because dementia is a life-limiting illness. So what is the work that I do through the Pepper Center? So I'm looking at the co-occurrence of peripheral arterial disease and Alzheimer's disease on mobility, falls, and other patient-centered outcomes in older adults. This matters, again, because Alzheimer's disease is a life-limiting condition. Importantly, early peripheral arterial disease is not a life-limiting condition. It is a quality of life condition. And so we absolutely should try to improve quality of life for patients, all patients, including those with Alzheimer's disease. But the treatment should never be worse than the disease. I think we all agree that by trying to improve their quality of life, we should never do something that doesn't meet their goals, especially for a condition like claudication that does not lead to increased death. This is unpublished data from our primary analysis. We're looking at outcomes of surgery for claudication in patients with ADRD. As you can tell from the Kaplan-Meier curve here, patients without dementia survive longer than patients with dementia, not dementia in blue, yes, dementia in red. So then we have to ask ourselves, all patients with dementia do worse. So does subjecting patients to surgery or minimally invasive surgery for leg artery disease, does it improve quality of life outcomes? Because we know that it's not going to improve survival. And what we found preliminarily is you're much more likely to be readmitted, almost 2 times as much in a 90-day period if you have dementia. You're about 2 times less likely to go home, more likely to be discharged to a higher level of care. You're about half as much likely to go home. And so when you are having conversations with your patients and their caregivers, you can tell the person in front of you, compared to a patient without dementia, you or your loved one is equally likely to survive with the procedure. We're not going to necessarily harm you, but you're less likely to spend your days at home over 1 year, and you're actually less likely to be discharged home and more likely to go to a skilled nursing facility when you undergo surgery for this quality of life limiting condition. And then the conversation starts there. So how much is their quality of life limited? Is having surgery worth spending less time at home based on the limitations in their quality of life? And the conversation just gets deeper and more meaningful from there. So with that, I'd like to stop and leave some time for questions. I want to just take a moment to thank the University of Florida Pepper Center leadership, Doctors Christian Leuenberg and Todd Manini, who have really invested their energy, resources in me. And then of course, my mentorship team for this project and other projects. And I'd love to keep these conversations going. My email is there as well as my cell phone. Thank you very much for your time.
Hi, Dr. Shah. It's Sarah Bradley. I'm actually at O'Hare Airport, so excuse my background here, but that was such a great talk and so important. It's exactly what we hear from our patients all the time, that there's so many more things that are important to them besides what the doctors are necessarily talking about. And while we always say a picture says 1,000 words, I think the voice of your patient really was so powerful. So thank you for sharing that. And this is such great work. I am going to see in the chat if we have any questions. Please do post them in the chat if you have any. You have time for questions. I'm not seeing any right now. I think it's just so great that you're doing this, and I think so many of our patients, living longer isn't their goal. It's quality of life. But even for the same, these two patients who might look alike on paper with the same numbers, the same heart function, the same age, what's important to them may be vastly different, and so it really does have to be so individualized. You can't make assumptions about this patient population. That's for sure.
That's the truth. Absolutely. And I think, not only are we learning this, but also regulators, payers, everyone's learning this. So.
I'm not seeing any questions in the chat, but this is great work, and we're definitely going to have you come back again with an update at some point. But this is really, really wonderful. So thank you so much for sharing it with us today, and thank you everyone else for joining.
Thank you so much for your time. I appreciate it.